So to recap briefly, in part one, we had a very quick overview of pharmacokinetics, absorption, distribution, metabolism, and excretion, with a focus on metabolism. We briefly distinguished between phase 1 and phase 2 metabolic reactions. In the second part of our presentation, we looked more closely at CYP450 enzymes. These are enzymes that are very important in metabolism in the human body. They're found throughout the human body, but they tend to be found more predominantly in the liver. We talked about induction and inhibition of CYP450 enzymes, and we started a discussion of pharmacogenetics of CYP450 enzymes as well. And when we say pharmacogenetics, we really mean those genetic differences that are seen at the genetic level, at the gene and DNA level, that impact the expression of these CYP450 enzymes and some impacts that they would also have on metabolism. In this part of our presentation, what I want to do is to give you some clinical orientation to this idea of metabolism and drug response. So I do have a case study, and I also have some data from an article that I'd like to share with you. So the first case study that we have, this was published in The Lancet in 2006. And it involves a breastfeeding mother with an uneventful delivery of a baby boy. Mother has been prescribed codeine 30 milligrams and paracetamol 500 milligrams. Paracetamol is a European name for acetaminophen or Tylenol. And she was prescribed this pain medication for episiotomy pain. I'll tell you here that this mother actually was prescribed 2 tablets, which she found to be very sedating, and so she actually was only taking half of the recommended dose, or half of the prescribed dose. Very tragically, the baby was having difficulty, and on day 13 postpartum, the baby was dead. The blood concentration of morphine in the baby was found to be 70 nanograms per mil, and the breast milk concentration of morphine was also found to be very high at 87 nanograms per milliliter. And you can see the expected concentrations there in the parentheses. So to understand what happened in this very tragic case, I need to start with a kind of an understanding of the metabolism of codeine and morphine. So in this slide, I have a schematic of the codeine metabolism. You see codeine. Oops. Sorry, I cannot find my cursor. Here it is. We have codeine right here. Codeine is going to be metabolized by multiple pathways, and both of these that I'm showing here are actually CYP450 pathways. The majority of codeine will actually be metabolized this way, but about 10% of any given dose of codeine will be metabolized by CYP2D6 to make morphine. Now, there are 2 things that I want to say about CYP2D6, or 2 things that I want to review with you about this. And the first is that in terms of CYP450 enzymes, the 2D6 is an important enzyme. It is responsible for the metabolism of somewhere in the neighborhood of 25% of all known drugs and xenobiotics. The second thing that I want to remind you of is that CYP2D6 is not inducible, which means that we don't see the kinds of drug interactions or food-drug interactions that result in change in activity of the enzyme. We do, however, see a large variation in patient response to codeine, and you, in fact, in your own practice, may be aware that you have some patients that get very adequate pain relief from codeine and some patients that don't get very good pain relief from codeine and you need to use something else. Okay. This variability, because the enzyme is not, or the gene that codes for the enzyme is not inducible, has been attributed to polymorphisms, or genetic differences in the genetic codes of some patients that allow them, or that produce more enzyme molecules literally in those patients. Okay, so the first step of our codeine metabolism involves a phase 1 reaction. About 10% of a dose, any given dose of codeine, is going to be metabolized by CYP450 enzymes into morphine. And this morphine, of course, is believed to be responsible, very important, for the pain relieving response that your patient sees. Morphine in turn is going to undergo a phase 2 reaction by glucuronidation at either the 3 position or the 6 position. Morphine 6-glucuronide is actually important because it also is an active metabolite. When we say an active metabolite, we mean that it has the same activity as the parent compound. So pain relief will result from the production of morphine, and pain relief will also result from the production of the morphine 6-glucuronide. So just to recap sort of briefly, in the metabolism of codeine, about 10%, will be metabolized by CYP2D6 to morphine. Morphine then also can be glucuronidated in a phase 2 reaction to a second active metabolite, the morphine 6-glucuronide. So now I want to step away from this just a little bit, and I want to look at some data from a study that was done in about 2002, I believe. And this study, I'll show you kind of the schema of this. This study involved children having a tonsillectomy in a hospital in London, I believe. Half of the children, after they received consent to observe these children, half of the children after the operation received morphine and diclofenac. This is a non-steroidal anti-inflammatory, and this was for pain. Half of the children received codeine and diclofenac after the operation. From all children, blood samples were obtained in part so that their genotype to the 2D6 enzyme could be determined. And then additionally, morphine levels, the M3 and the M6, or morphine 3-glucuronide and morphine 6-glucuronide, were obtained from those blood samples throughout their post-op recovery. Additionally, various measures related to pain relief, nausea, vomiting, and sedation were made of the children that were participating in the study. So the first thing that happened was that the children who received morphine and codeine, they looked at the CYP2D6 genotype, and they divided the children into, based on the alleles that were present or based on their genetic makeup, they divided them into 4 phenotypic groups, 4 distinct phenotypes, and they called these phenotypes poor metabolizers, or P, intermediate poor metabolizers, or IM/P, intermediate metabolizers, and extensive metabolizers. And remember, they are defining the phenotype here according to the genotype that they are obtaining from the blood sample that they've taken from the participating children. Now this particular figure, this is figure 2, and notice that there are 4 panels here. These are just the codeine children, the children that received codeine and diclofenac after their operation, and each panel we're looking at a different compound in the blood. So in panel B, we're looking at morphine in the plasma. In panel C, we're looking at the 3-glucuronide, and in panel D, we're looking at the morphine 6-glucuronide. And what I want to show you here is that the children that were determined to be poor metabolizers on the basis of their genotype, on the basis of the number of alleles that they had on their genes that code for the D26 enzyme, the poor metabolizers had no morphine in their plasma, and likewise they had no metabolite, neither metabolite. Okay. If we look at the extensive metabolizers over here, the children that were determined to be extensive metabolizers did actually contain, their plasma did contain morphine, and their plasma contained the 2 metabolites as well. Okay, so this would seem to indicate that the children that were poor metabolizers were not able to produce morphine at all, and the children that were classified as being extensive metabolizers were able to produce morphine. Now some other things that I'll tell you here were that the children that had been classified as being extensive metabolizers also had higher measures of sedation and higher levels or higher measures of nausea and vomiting, whereas the poor metabolizers had lower scores on those measures. So they were less sedated, they also had less nausea and vomiting. However, the poor metabolizers, the children that were classified as being poor metabolizers, also required were more likely to require rescue analgesia, so they didn't appear to have as good pain relief. Okay, right. since this time, we've updated our likely phenotypes a little bit, and I've put these into a chart here. So the 4 phenotypes that we're likely to see with respect to codeine metabolism related to CYP2D6 expression are ultra rapid, extensive, intermediate, and poor metabolizer. If we were to look at the activity that we would see on a score of, really this looks like from 1 to 2, if we were to look at a score that these patients would get on their ability to metabolize codeine, we would see that the ultra rapid metabolizers have a very high score, whereas the poor metabolizers have a low score or a 0 score. And in between, our intermediate and our extensive metabolizers have an intermediate score. Okay. Genotypically, what this looks like is that ultra-rapid metabolizers have more than 2 copies of functional alleles. So they have alleles or genes that are coding for CYP2D6, whereas our poor metabolizers, if we look here at the bottom, these individuals have no functional alleles. And our intermediate and our extensive metabolizers are going to have some combination of dysfunctional or reduced functioning alleles in between. Okay, so far you should be able to see the connection between the genotype, the number of functional alleles that any of these patients have, and their ability to metabolize codeine. Now, what does this mean for me in my practice? Well, what this means is that if you understood the genetic makeup of your patients with respect to codeine, with respect to the 2D6, then you might be able to make a rational decision about the use of codeine in these particular patients. Now, in this table, I also have included recommendations for codeine therapy in particular. And you can see that with ultra-rapid metabolizers, those that have multiple copies of functional alleles, those that are very, very good at metabolizing the codeine to the morphine, codeine use should be avoided in those people. Likewise, in poor metabolizers here, these are patients that have no functional alleles. These are patients that cannot metabolize codeine into morphine. Likewise, we also should avoid codeine use in these people, but for opposite reasons. In our poor metabolizers, we should avoid codeine use because it doesn't work very well. They don't get good pain relief. Whereas in our ultra-rapid metabolizers, we should avoid codeine use because that puts those patients at a higher risk of toxicity, including death. So the takeaway message from a table like this is that if you understood your patient's genetic makeup with respect to metabolizing enzymes, you would be able to choose the most appropriate, most effective drug, the most appropriate, the most effective dose of that drug. You would decrease the risk associated with that drug in your patient. You would decrease the cost to your patient because they wouldn't have to go between different drugs, and you might possibly increase compliance of your patient with this drug. Okay. Now, where did those recommended guidelines come from? There actually is an organization, the Clinical Pharmacogenetic Implementation Consortium, and if I can, there we go, I'll show you this website. This is actually run in part by the Health and Human Resources Administration, and they have dosing guidelines not just for codeine with respect to CYP2D6, but for any number of other drugs. So it's a very useful resource in that way. Okay. Now, going back to our patient then, and thinking about what we've just discussed with respect to metabolism and codeine and morphine, what do we think has happened with the mother and the baby?